Associate Professor of Biology here at Eugene College, and I was the coordinator of the Hunt Foundation Summer Science Fellows, Science and Math Fellows. And I had mentioned earlier in my introduction that Stephen and Alexa and I all went to City Hall and were protesting, so you can actually see the three of us up in the middle there. We have like a close-up picture here. And one of the things that I think is so interesting, again, about commitment and dedication is you might notice that Alexa is not smiling as her usual self. And it's because Alexa was on her deathbed on this day, and yet she came not just for this protest, but an earlier protest that day. So she was there for a good 3-4 hours that morning. And so that's the kind of commitment that our students have. I also just wanted to help you understand, again, the difference in structure between our programs. So because this was a pilot program, our students were only working part-time, and their work started in the spring semester. So the work that they're going to be presenting today actually takes place over about 4 or 5 months. Some of the time where they were only working 5 to 10 hours a week, other weeks where they were working up to 25 to 35 hours a week, depending on the summer versus the spring semester. And so the work looks a little bit different, and the nature of the work and the depth of the work is a little different, and I just wanted to highlight that. So I'll just let the students speak for themselves, and we're going to begin with Stephen Houang, and then Alexa will follow. I think this is you, right?
Yep.
Okay, great. And I will do
8 and 10.
Okay.
Great. Hi, everyone. Thank you for coming. It's really makes me happy to see some of the familiar faces, but also excited to meet some of the unfamiliar faces. So like Kathleen said, my name is Stephen Houang, and I am a senior in the Interdisciplinary Science program. I'm about to graduate in December. And this past year, I conducted an internship at the New York City Department of Health and Mental Hygiene on quality improvement for the care of individuals living with HIV and AIDS. And it was a very data-driven project that helped develop my analytical skills, but also allowed me to examine some of my interests in health and social justice. So first, a little bit of history on HIV and AIDS in the United States. Then I'll briefly discuss my project, and hopefully we'll have some discussion at the end. Ryan White was 13 when he was diagnosed with full-blown AIDS. He was a hemophiliac, and it was thought that he contracted the virus from regular blood transfusions. And because of the lack of information and the stigma around the disease at the time, there wasn't really a lot of information. He was eventually prevented from going to school and ultimately was expelled. Several years later, after he died, he became kind of the face for the national movement for advocacy for care and treatment, and also more research. This is President Obama at a press conference addressing the HIV/AIDS epidemic in the United States. And as a nation, we have a national HIV/AIDS strategy that looks at prevention, so reducing the transmission rate of the disease, but also care and treatment, so looking at who gets to access care, and also addressing disparities and inequalities in the system in order to achieve, quote, a more coordinated response to the HIV epidemic in the United States. And so this is kind of the national language that we have that frames what's called a care continuum model, where we make the diagnosis, then we link them to the HIV positive individuals to care. And this was extremely important to me because in our science program, we learn about the etiology of the disease, we learn about the biology and the molecular mechanisms, and then we think about policy, but then what? So this was really important to me to kind of understand what goes on after people are diagnosed and what happens when you need to link them to care and treatment. In my position at the Department of Health, I work to support the monitoring of a program called Care Coordination. I was able to help in the development of slides for a national webinar, which you see here, where we introduced the Care Coordination program to agencies such as hospitals and community-based organizations around the country. This is a modified slide from that webinar. And so care coordination really stresses the team-based approach of involving the patient along with the patient navigator and their primary care providers. Even though we have Obamacare and the Affordable Care Act, navigating your healthcare is an extremely difficult process, even for people who are not diagnosed with HIV and AIDS. Imagine the complexity of disease management in that situation. And so a cornerstone of the care coordination program is the patient navigator. And this is a staff member who tries to meet the patient where they're at and builds up their skills and abilities so that they're autonomous enough and empowered to make decisions regarding their own health care, and in order for them to manage the nuances of health care. The target population that the care coordination program seeks to serve are people who might be newly diagnosed, they might be previously lost to care or irregularly in care, and this might be due to issues such as mental health or housing instability. They also might have recent adherence issues such as viral rebound or resistance issues with HIV 1 and 2. And through Ryan White funding, the care coordination program is implemented at almost 30 agencies throughout all 5 boroughs of New York City. And I think it's very telling that Ryan White, who was a young, white, photogenic young male, was the impetus that started the movement. But today, it's a pair of last resort for many people. So people who are typically from a lower socioeconomic status, people who are on some form of public insurance, and a large majority are people of color. We represent people who are served who might identify as transgender, female, or male, along with a range of risk factors. So basically, there's a confluence of factors that contributes to a person needing this access to the safety net of safety nets. The way the program works is typically a program director oversees a staff of care coordinators who will manage patient navigators. And these patient navigators are the ones who go out into the fields, into patient homes, and they spend a tremendous amount of time and energy in order to interact with the patient and make sure that they are able to take care of themselves and manage their needs between their primary care physicians or their HIV care specialists. People living with HIV and AIDS in care cost a lot less than people who are not in care, and they have a significant impact on the communities that they're a part of. Now, working at the Department of Health allowed me the special privilege of seeing a systematic behind-the-scenes view of what it takes to implement and sustain a public health program. One of the ways that tells us what or how we're doing is through data. And today, in almost every single sector, there's a lot of talk about big data. Data is everywhere, and what forms does it take? What does it mean when you need to make meaning out of it, and how do you do that? And at the Department of Health, we collect vital statistics to inform on the interventions that we're implementing. We also collect data on how the programs are doing in order to support different agencies using the care coordination model. Data is able to contribute to the evidence that we use to build and guide our interventions. This is an example of a modified slide, and it's an example of the evidence that supports the effectiveness of care coordination. This was a short-term evaluation that looked at the percentage of a cohort of people enrolled in care coordination who had suppressed viral loads. So the percentage of people who had suppressed viral loads before and after the program. So in dark blue, you see an increase from 36% before the program to 54%, and that's a statistically significant improvement. The time and effort study was one of the studies that I worked on, and we were interested in improving the quality of care at different agencies that were using the care coordination model. So we asked a sample of program staff to record what they did with their time every 15 minutes for 2 weeks. This generated a lot of data, not all of which was immediately usable. And one of my contributions was to clean that data, which was no small feat. There were over 170,000 lines of data with about 40 variables. And then for each variable, you had a list of dozens of possible values for each cell. And so that cleaning process took about 3 months. I also helped with the analysis, which led to a larger discussion of possible program changes in order to better serve patients. And this drew on some of the technical skills that I learned from Lang. These are some of the slides from that national webinar. The top left shows that out of a sample of 35 patient navigators, the average number of hours that they worked is 7.37, with a majority of the time spent on indirect and direct patient services, which is what we expected. The second slide on the bottom shows that out of all of the client services, travel to and from the patient encounters took up a majority of the time. And remember, this is because that in order to conduct health promotion, and skill building with their regular patients, the navigators have to go out into the field and meet them in their home or in a public space where the patient might be more comfortable because they might have concerns about confidentiality and don't want somebody coming to their home. And as if I didn't get enough exposure to social justice in the healthcare system, I also got to see an example of procedural justice in action. Now, procedural justice is an example of being concerned with the fair representation and participation in decision making. This is an article from Out magazine, and it's about when ACT UP, the AIDS Coalition to Unleash Power, protested the Department of Health. This happened during the last week of my internship, and they were protesting cuts in funding and, of all things, access to data. But this was actually really difficult for me to understand because primarily I worked in care and treatment, not really in prevention, and also because the Department of Health releases a biannual epidemiology report. They also make their data freely available on their website, but also has a data release system where you can request data that you don't see on the website. Later on during the protests, the members of ACT UP were able to come inside the building and attend the planning council meeting, where famous activists that you would see on documentaries like How to Survive a Plague were able to voice their concerns and were heard and considered. For me, this was an important moment that really underlined how important the work we were doing in the lives of thousands of people, and were looked to as a national example through things such as the national webinar. A few last thoughts. So last summer, I have a background in restaurants, and so last summer I worked in a restaurant where I was constantly being yelled at, and I burned my hands carrying hot dishes, in these like artisan handmade ceramic bowls. This summer, I was provided with numerous opportunities to enrich and connect my professional and personal interests. Along with a part-time job, and thanks to the Hunt Foundation, I was actually able to pursue this internship full-time. I attended events like career panels, pharmacy talks, public health laboratory visits, and I also went to their journal clubs and reviewed literature through regular updates. I also went on site visits for different agencies where I reviewed patient charts and understood through the deeply personal notes that providers were writing in their charts what are some of the structural and institutional challenges that really face erect barriers for people living with HIV and AIDS, such as education and literacy. In working in the time and effort study, I was really enticed by the potential for research and creating meaning through big data. And after graduation, I would like to pursue a master's in public health with a focus on health information technology. Some last notes. I just want to thank the people at the New York City Department of Health and Mental Hygiene. The directors and project officers offered me priceless advice and allowed me to see what the daily operation at the most innovative public health agency is like. I'm also grateful to the Hunt Foundation, who provided their generous grant, without which I wouldn't have been able to work full-time. Last and most importantly, I want to thank Dr. Kathleen Chamini and the faculty at the Interdisciplinary Science program, because they not only did they prepare me, but they also pushed me to see the connections in between the data. Thank you.
Any questions for Stephen?
Hi, Stephen. So it sounded like the care coordinating program uses a harm reduction model. Is that the case? You said meet them where they're at. So
it meets them where they're at in the sense that you don't have to necessarily be on antiretroviral therapy to be in the program. You can be enrolled in the program and not be taking medication up to, because the problem really is that if you're at a place where you're homeless and you don't have food coming in, you're not going to be concerned with taking a pill every day. And if you're taking only about 60%, 70% of the pills, that really creates viral resistance. So it's really about putting patients in the program so you can start to come in and provide weekly health promotion events. So building up their skills so that they can eventually become more autonomous and empowered to make those decisions so that they can start taking, antiretrovirals and manage their health.
Cool.
I felt like you almost said you can be enrolled in the program for a certain amount of time, and then you are, hopefully equipped well enough to be able to start antiretrovirals. Is there like a cap or a minimum or something like that?
I mean, that's the hope, and I think some of the experts in the room can answer that a little better than I can. But the program really is meant to be kind of a limited up to a year.
Okay.
Is that right? Okay, great.
I'm greedy for your knowledge. Okay, so information technologies. Could you explain a little bit more what those look like?
Yeah, so, I was able to go on these site visits, and I saw some community-based organizations who had paper charts, and I saw some better equipped hospitals who had electronic medical records, EMRs, which is kind of the big thing now, because you want to be able to connect all of the different information that a patient has, because you're going to your primary care physician for, maybe health and nutrition issues. You're going to your HIV specialist. You might be going somewhere else for your labs. So you really need a place to kind of centralize all of that information. But also through some of the seminars and events that I went to at the Department of Health, I was able to kind of understand some of the initiatives around the city where they're actually pulling data from primary care physicians and then crunching those numbers, and every month they send out a report. So that kind of, because data really is everywhere. Everything you do, there's like a metric associated with it. And some of the debate is, is it too qualitative? Is it not qualitative enough? Is it too quantitative? But I'm really interested in how you're able to make meaning out of all of this information that we have, because we're just kind of, through our smartphones, through sequencing our genomes, there's a plethora of information available, and we don't always know what it means. Thank you.
Thank you, Stephen.